Okay, we all know about exudative ARMD, the three loading doses, whether you're dealing with predominantly classic, progressive occult, or progressive minimally classic CNV. And please keep in mind, when you talk of occult or minimally classic lesions, treatment is only given when you're talking of progressive lesions, not a stationary lesion. Now, the fact remains that for subfoveal ARMD, even today, the gold standard remains monthly treatment. Till recently, it was monthly treatment with ranibizumab. Now it's become aflibercept after the first three doses, the 2 monthly treatment. But the point is that this monthly treatment or fixed dose treatment is extremely intensive. And everyone feels it'll be exhausting for both the patient and the doctor, and it is exhausting. But remember, in an occupationally active patient who is fit and who's working, you can carry this out month after month for years. And I have patients who've been on treatment month after month when required. However, we do need to individualize the approach to management so that we minimize the number of injections in every patient. And can we do that? Well, the fact is that the sustained study showed us that there were 20% patients who would need no further retreatments after the first 3 injections for the rest of the year. That means if you put these patients on treat and extend treatment, you imagine how many extra treatments you're giving these patients. Another 33% of patients could do with another 1 or 2 retreatments, but there are patients who would need monthly treatment too. So you need to individualize your treatment. Now, this is a patient who showed a beautiful response to 1 treatment, and we'll discuss whether you can stop here or you need to do anything more after that. What you will see is that if we give quarterly treatment with ranibizumab, you can actually have adequate treatment for more than 40% of patients. That means once in 3 months injections. But in another quarter, 1/3 of the patients, this is inadequate and the vision will drop and the initial gains you've got will go down to 0 by the end of the year. And there will be another 20% of patients who do not seem to respond to anything like a quarterly treatment, and they need probably monthly treatments. What is the basic objective of our treatment? Well, basically our objective is to dry the lesion. And if you can't dry the lesion, then at least don't let the fluid increase and avoid too much fluctuation of the fluid. And we'll also discuss why. And finally, don't dry your lesion at the expense of losing visual acuity. So how can you do that? So give your loading doses. After you've given 3 loading doses, you see the response. If your patient has a dry lesion now and the vision is stable or improved, you reached an endpoint. And this patient does not need any more injections. This patient can be followed up and be given PRN treatment if required. With monthly monitoring, if there is no recurrence over the next 3 months, you can now progressively increase the duration between the monitoring visits from 4 weeks to 6 weeks to 8 weeks to 10 weeks and finally 3 months. But every 3 months, the patient will continue to follow up. However, if the patient gets a recurrence during these next 3 months, the PRN treatment with monthly follow-ups will continue and you continue to monitor this patient monthly. These loading doses, we used to previously give only ranibizumab, but you can also use aflibercept. But I will explain to you that I am a little careful about giving aflibercept as the initial treatment because I believe that there may be a higher risk of geographic atrophy in long-term intensive use of aflibercept in Asian patients. And I will show you that subsequently. There is one category of patients where if you have a dry lesion, a treat and extend could still be an acceptable alternative. These are one-eyed patients who have a dry lesion after their first 3 injections. Now remember one more thing. If the patient is on PRN treatment and is requiring an injection of ranibizumab almost every 6 weekly or 4 weekly, this patient should be considered for shifting to aflibercept. This is just to show you a patient who was given for 1 recurrence, a little bit of fluid. He was given an injection and you can see the patient did not need any treatment for the next 6 months. So you don't want to unnecessarily treat these patients. So when do you stop your treatment? Now, one more thing you must keep on in mind. Sometimes you're given 1 injection especially in classic CNV, and it resolves. So should we stop? No. So if you have a patient who given the first injection, you must have at least minimum 2 consecutive OCTs in which the lesion is dry, after which you decide not to give any more injections. So the minimum number of injections really becomes 2. This kind of thing can happen more in myopic CNVs rather than ARMD. The more important group, and management of this group will decide whether you are able to bring the number of injections to a lowest number, is at month 3, the vision has improved or is stable, but the lesion is not dry. In this situation, you continue monthly for the next 3 months till it becomes dry. If it dries in the next 3 months, now go to the same paradigm which we said before, PRN with monitor and extend. If it does not dry, these are the patients who have either little bit of intraretinal cystic fluid or subretinal fluid. Put them on a treat and extend regime and keep on seeing whether the fluid, if the fluid doesn't increase, go from 4 weeks to 6 weeks, 6 weeks to 8 weeks till you reach quarterly injections. Alternatively, you could also consider a trial of aflibercept in these patients and see whether that works. The other important thing which is now coming in is, since costs are becoming lesser, you may want to try 3 loading doses of aflibercept followed by a treat and extend regime in patients who are dry but who are stable but not dry, and see whether you can end up giving the injection once in 8 weeks or more at even higher intervals. If you can do that, you continue with aflibercept. If you can't, you may need to go to ranibizumab. Just to show you a patient whom we started with aflibercept, the initial fluid went away, but there was some delay in one treatment. So the second treatment, third treatment, and looked as if the fluid has gone, almost very minimal left. We gave an eccentrics here, thinking that now we can maintain on this. But the fluid came back, started coming back. We gave aflibercept, and we realized every 4 to 6 weeks we were requiring injections of aflibercept. And then finally, over here, you see, we finally got a response. The patient was supposed to come back for a treat and extend regime, but came late. Recurrence occurred, huge amount of fluid came back. And then we could not manage with even 2 repeated aflibercept injections. Now, the point of this entire case study is to show you aflibercept is not a panacea. It doesn't mean you started with aflibercept, you'll get complete resolution. It may not happen. If that does not happen, you may have to try to do a treat and extend with aflibercept and see the minimum number of injections that you need. If you can bring this interval beyond 8 weeks, that means you need to give aflibercept once in 8 weeks or so, you continue with aflibercept. If you can't do that, it's better to shift to intravitreal ranibizumab in these patients. How do you manage? This is a paradigm I created for managing with aflibercept. If at the end of your first 3 injections, lesion is dry, now see, can you maintain this patient with ranibizumab because it's a less toxic drug compared to aflibercept? If you can reach a treat and extend interval with ranibizumab, which is greater than 6 weeks, then maintain on ranibizumab. If you can't maintain this interval, go to treat and extend aflibercept and see with aflibercept, are we able to maintain the patient on greater than 8-week intervals? If you can, that's the way to go. If both aflibercept and ranibizumab are needed 4 to 6 weekly, then between the two, I would prefer to give ranibizumab because it will cause less geographic atrophy. Now, just to show you a patient who was on ranibizumab, but is requiring injections every 6 weeks or so, so we decided to give to this patient, we gave aflibercept. Now you see over here, responded in 1 injection, but every 6 weeks, the patient was getting ranibizumab. So we changed over to aflibercept, and you saw the lesion resolved. And now we see the recurrence starts occurring at around 8 weeks. So we gave this treatment, wanted to explore whether we can go to 10 weeks. We got the recurrence at 10 weeks. So again, we went back. This time it lasted at 10 weeks, but by 12 weeks, recurrence had occurred. So we realized that this patient's maximum tolerance is 10 weeks. We have now maintained this patient on 10 weekly injections of aflibercept, which is a great, very few injections required. This is a patient, a third patient, where we used aflibercept as a rescue. Patient lost vision from 6/9 to 6/18 despite ranibizumab monthly. was given aflibercept, responded completely, and then was maintained on ranibizumab, as I told you. Despite the fact that he was only being used for rescue aflibercept with 3-4 aflibercepts a year, I will show you what happened to the macula. And you may be wondering, why do I say there has to be caution? You see over here the View 1 and View 2 trials. Nobody shows you the differentiation. With View 1, 2 milligram, 4 weekly injections are the best outcome. But when you come to View 2, they give the worst outcome. But the drying of the lesion is equally good in both View 1 and View 2 with 2 milligrams, 4 weekly injections. Why? It seems to suggest that that injection is causing the drying, but also seems to be causing geographic atrophy. And so the vision doesn't improve. And this is what we saw in this patient. This patient started off in Jan 2016 with this picture. And by 2019, we had extensive geographic atrophy. Fortunately for us, most of it is extrafoveal and juxtafoveal. The fovea is okay, and so his vision is maintained. This patient has only received a few injections of aflibercept, and before that, he was being maintained only on ranibizumab. Now, it could be because the number of years which have gone by, but it could be that aflibercept initiated something that otherwise may not have happened. Now, as far as when to stop, because you keep on giving injections, the number of injections will increase. If you have no fluid on OCT, like you see here, then should we give once more? Now, as I said before, if you've started the treatment and this is the initiation of the treatment, then before you stop treatment, you give at least 2 injections with no fluid. That means you have 2 OCTs, no fluid, before you say no more injections. But when you're doing PRN treatment and the patient gets a recurrence, you give an injection, fluid goes away, I will not give another injection during the recurrences. This is another thing which you don't bother to treat. This is a solid RPED. The main fluid is all gone. You don't have to keep on treating this. We know ranibizumab does not remove this. Aflibercept sometimes does and sometimes does not. So you do not have to treat this. Of course, if you have patients with this kind of picture, only if they have useful vision or if this is the better eye, you may want to treat it. Otherwise, you will not be treating them. The important thing is that if you do not get a response to 3 injections of ranibizumab, consider aflibercept if it's an occult lesion, or combination therapy with PDT if it is a classic lesion. We know that works. And finally, we are getting pralucizumab now. And if you got patients who are not responding to aflibercept, you could consider giving pralucizumab if that is the worst eye of the patient. You must also know when not to treat. If you have a lesion like this, and this is the worst eye, and the vision is less than 3/60, you actually don't need to treat it. Otherwise, you can keep on treating, nothing's going to happen. If you have a scar formation, this hemorrhage is an old one, and the patient's not worsening, no, you need not treat this. The only indication could be if you believe that this scar may have a propensity to enlarge and increase the scotoma. The third important thing, and this is the most controversial, if you have a patient with a PED, normal fovea, 6/6 vision, you may not need to treat this patient unless you see progression in this patient. Progressive occult lesions need to be treated. Stationary occult lesions can be followed up closely. Now, we talk about drying of the lesion. Should we dry? Because people say, no, you can leave some fluid. Well, we would dry if they have a better prognosis, isn't it? And the Altair study showed that they do. The visual acuity, the visual outcome in patients whose eyes were dry within 16 weeks was better, almost double the visual outcome as compared to those who were not dry at 16 weeks. So that first 16 weeks will tell you how well your patient will do over the next 2 years. Also, if they dried, they needed less number of injections. That means there's a higher possibility of even cessation of treatment. So you would want to dry your lesions. Even more important, what we've seen is in a post hoc analysis of Excite, that lesions which remain dry for a longer period before the fluid came back, like over here, the fluid came back at month 3, this came back at month 4, the worst prognosis. These, it came back at 5 or did not come back, better prognosis. So if we can keep intraretinal cysts out, you have the best prognosis. With regards to subretinal fluid, its presence does not make as much of a difference. So a little bit of subretinal fluid, if it's present, it does not harm the final outcome so much as what you see in intraretinal fluid. See what happened with intraretinal fluid. If it's constant and if it's foveal, the visual outcome goes down very, very tremendously. So we don't want to leave intraretinal fluid. It's not well tolerated. But RPE detachments, with at least with ranibizumab, did not show a change, and that is why it's not so important. The last important thing which tells about what to do and how to manage is this was the Hawk and Harrier study, and they compared patients in whom there was maximum fluid left of various types, intraretinal, subretinal, or PED, and compared with the rest who had very low limits of fluid to see whether this makes a difference. And what did they find? They find whether it's intraretinal fluid or subretinal fluid or pigment epithelial detachment, the patients who have minimal fluid seem to do the best. They have better visual outcomes. So this is what we want to do. Least number of injections with least amount of fluid. But you can see that for PEDs, this difference is not too much even in the Asian patients, in the Harrier. Harrier had the Asian patients. The other important thing, if you can't remove the fluid completely, let there be minimum fluctuation. And this is what was again came out from the Hawk and Harrier study. Patients who had minimum amount of variation in fluctuation in fluid got the best visual outcomes. Those with the maximum amount of variation, over 68 micron, got the worst visual outcomes. So ladies and gentlemen, this is important. We want to dry. To dry, we use the second paradigm, which I told you, stabilize the fluid and see the minimum number of injections that keeps your patient absolutely stable. We don't want to let the fluid increase, but we will try to give the minimum number of injections to keep it where it is. Persistent fluid is not better than dry lesion. This is, if anyone says that, is the sign of a fox calling the grapes sour because she cannot get them. We are making a virtue out of a necessity. We know we can't remove that last bit of fluid, so we say, oh, it's very good for us. We are accepting a fait accompli to make a victory out of our failure. But what is our objective? Dry the lesion. When it doesn't dry, do the next best thing, find the minimum number of injections that prevents the fluid from increasing, and accept this is the next achievable objective, whichever the drug which achieves it, whether it's ranibizumab or aflibercept, or now if of brodalumab as it comes next. This will ensure number of injections is minimized over the long term without compromising visual outcomes. With newer drugs like brodalumab now available, we may be able to dry various types of fluid more effectively and consistently. In fact, in the Hawk and Harrier, they showed 76% of the fluid of the lesions dried after the loading dose at 16 weeks. So, ladies and gentlemen, we have exciting, good times for our patients, and we can keep our patients going for a long, long time. And I hope we will all do our best to do that as well as we can. Thank you very much.
Thank you, Dinesh, for explaining